Imagine a disease so cunning, so deceptive, it's baffled doctors for centuries. It's reshaped empires, inspired art, even driven brilliant minds to madness. A disease that can lie dormant for years, silently causing damage, only to pop up with symptoms that mimic countless other illnesses. Its infamous nickname, the Great Imitator. Okay, let's unpack this. Today, we're diving deep into syphilis, and this isn't just about the clinical facts. It's about tracing the fascinating historical threads, the societal impact. It's a really complex story. Our mission, to give you a shortcut to being genuinely well-informed about a disease that's both ancient and maybe surprisingly, alarmingly current. We'll touch on the science, prevention, and its pretty profound impact on human history.
Yeah, and what's really striking, I think, especially for us as medical professionals, is that even though we've had effective cures, antibiotics for decades, syphilis is actually seeing a global resurgence right now. So this isn't just some historical curiosity, it's a significant public health issue today. Understanding its nuances, its many disguises, is absolutely critical, whether you're in a clinic or just trying to stay informed about health.
Right. So to really grasp its cunning nature, how would you sort of paint a picture of syphilis for our listeners? What makes it such a notorious deceiver?
Okay, so at its core, syphilis is an STI, a sexually transmitted infection. It's caused by this tiny spiral-shaped bacterium called Treponema pallidum, and it's really the life cycle of this bacterium, with its distinct stages where symptoms can just vanish, that earns it the name the Great Imitator. Now, we can cure it, thankfully, with antibiotics like penicillin, but if it's left untreated, this little organism can cause really severe health problems, even death.
Yeah.
It's that stage progression, primary, secondary, latent, and tertiary, that makes it so incredibly tricky.
The 4 acts, you call them.
Exactly. Let's walk through those because recognizing them is key to unmasking it. The first act, the primary stage, usually shows up about, say, 3 weeks after infection. The main symptom here is a small sore. We call it a chancre. It typically appears right where the bacteria entered the body, so often genitals, anus, maybe the mouth or lips. But here's the really insidious part. It's almost always painless. Firm, round, but no pain. Because it doesn't hurt, it gets missed a lot, especially if it's somewhere you can't easily see. And then after 3 to 6 weeks, it just heals up on its own.
Heals on its own, so people think, oh, whatever that was, it's gone.
Precisely. But that's the deception. The infection isn't gone, it's just moved deeper into the body. Treatment is still absolutely necessary.
Okay, so if that painless sore is missed or ignored, what's Act 2?
Right. If it goes untreated, it progresses to the secondary stage. This might start as the chancre is healing, or maybe weeks later, and this is where the imitator really, puts on a show. A classic sign is a skin rash, often looks rough, red, or reddish-brown, and crucially, it usually doesn't itch.
Doesn't itch. That's unusual for a rash.
It is. It can appear anywhere, but a real telltale sign is when it shows up on the palms of the hands and the soles of the feet. You might also get sores in the mouth, vagina, or anus, and on top of that, think flu-like symptoms. Fever, swollen glands, sore throat, maybe patchy hair loss, headaches, weight loss, fatigue.
Wow, okay, so that could be mistaken for almost anything. Flu, mono, allergies.
Exactly. And here's the kicker. These symptoms, just like the chancre, also eventually go away on their own, even without treatment, which just reinforces that dangerous idea that, oh, I just had a weird bug, but I'm better now. Meanwhile, the infection is marching silently onward.
That's genuinely chilling. It's not just painless, it actively mimics common illnesses and then disappears, like a masterclass in medical misdirection. So what happens when it goes into hiding after this stage?
Well, if it's still untreated, the disease enters the latent stage. This is really the hidden stage. No signs, no symptoms at all. You feel perfectly fine, but the bacteria are still there, active in the body. And this latent stage can last for years, sometimes decades. All the while, it could be slowly causing internal damage. It's like a ticking clock.
Decades, wow. And then, the final act.
And then for some people who haven't been treated, not everyone, but a significant portion, it progresses to the tertiary stage or a late syphilis. This usually develops 10, 20, even 30 years after they were first infected. And this stage is incredibly serious, potentially life-threatening. The disease can cause irreversible damage to major organ systems. We're talking the heart, blood vessels, the brain, the nervous system.
So this is where you see things like neurosyphilis.
Exactly. Neurosyphilis can cause severe headaches, muscle problems, trouble moving, major changes to mental state confusion, personality shifts, even dementia. It can also affect the eyes, causing pain, redness, vision changes, sometimes blindness, that's ocular syphilis, or the ears, otosyphilis, leading to hearing loss, tinnitus, dizziness. We can also see these soft, non-cancerous growths called gummas appearing on skin, bones, the liver, other organs. The variety is just staggering. It really hammers home that Great Imitator nickname.
That progression from a quiet little sore to potentially devastating organ damage decades later. It's a powerful reminder of why catching it early is so vital. But the implications of this hidden progression seem especially tragic when it comes to congenital syphilis, right?
Absolutely. It's a critical concern. This happens when syphilis is passed from a pregnant person to their baby. Often the pregnant person doesn't even know they're infected because of those latent or missed stages. The consequences for the baby can be just catastrophic. Low birth weight, premature birth, stillbirth, or death soon after birth. And if the baby survives but isn't treated immediately, they can face severe, lifelong problems. Cataracts, deafness, seizures, bone deformities. It's heartbreaking.
Which brings us back to screening during pregnancy. This raises an important question. Why is that testing so absolutely critical? It seems obvious medically, but are there other layers?
It's non-negotiable, really. From a public health perspective, mandatory screening for all pregnant individuals at their first prenatal visit, and sometimes repeating it later in pregnancy for those at higher risk, is crucial. It's a simple blood test. And if the parent tests positive, timely treatment during pregnancy can prevent almost all of these devastating outcomes for the child. It's a fundamental responsibility, especially when you consider, historically, how diseases like syphilis have often hit marginalized communities harder due to access issues. Screening helps level that playing field.
Okay, so we've dissected the biological genius of this imitator and its insidious stages. But how does this cunning disease actually get around? How does it spread?
Primarily, it spreads through direct contact with the syphilis sore, that chancre we talked about, or the sores in the secondary stage. This contact usually happens during vaginal, anal, or oral sex. And, as we just discussed, it can pass from mother to baby during pregnancy or birth. It's really important to bust some myths here, too.
Good point. What doesn't spread it?
You cannot get syphilis from casual contact. Toilet seats, doorknobs, swimming pools, sharing cups or utensils, none of that. The bacteria are quite fragile and die quickly outside the body.
Okay, that's clear. And who is most at risk?
Well, technically, any sexually active person can get syphilis. But yes, certain groups face a higher risk. This includes people with multiple sexual partners. Men who have sex with men have been disproportionately affected by the recent resurgence in many countries. People living with HIV are also at higher risk, partly because their immune system might be more vulnerable, but also because the behaviors that transmit HIV can also transmit syphilis. And unfortunately, we do see higher rates in some racial and ethnic minority groups. This isn't biological. It's often tied to social determinants of health, things like poverty, lack of access to quality health care, stigma, discrimination. These factors create barriers, and there's a really important link with HIV. Those syphilis sores, the chancres, they basically provide an open door for the HIV virus to enter the body more easily during sex. So having syphilis significantly increases your risk of getting or transmitting HIV. They often travel together, sadly.
Given how tricky it is, with disappearing symptoms and mimicking other things, how do you actually diagnose it reliably and treat it?
Diagnosis is mainly done through blood tests. It's usually a two-step process. First, a screening test. If that's positive, we do a second, more specific test to confirm it's definitely syphilis and not something else cross-reacting. Sometimes, if there's an active sore, we can test fluid directly from it, but blood tests are the mainstay. And again, early diagnosis is just absolutely key to prevent those later serious stages.
And the treatment, is it still penicillin after all these years?
Yes, penicillin is still the gold standard. It's remarkably effective, especially in the early stages. The exact dose and how long you need treatment depends on the stage of syphilis you're in. Later stages need longer treatment courses. Now, one interesting thing about treatment, sometimes patients experience something called the Jerisch-Herxheimer reaction.
Oh, right. What exactly is that? Sounds a bit alarming.
It can be, yeah. Usually within hours of the first dose of antibiotics, some people develop temporary fever, chills, muscle aches, headache, basically feel quite unwell for a day or so. It seems counterintuitive, but it's actually thought to be caused by the immune system reacting to the large number of bacteria being killed off all at once. It's usually mild and self-limiting, but it's important we warn patients it might happen so they don't panic and stop treatment. It's actually a sign the medicine is working.
That's fascinating. Good to know. So, treatment cures the infection.
It cures the infection, yes. It kills the bacteria and stops the disease from progressing further. But, and this is a critical treatment, cannot undo damage that has already been done to organs in the tertiary stage. That damage is often permanent. Another reason why early detection is vital, also very important. Having syphilis once doesn't make you immune. You can absolutely get infected again if you're exposed again.
Right, no immunity. So, prevention is key. What are the best strategies?
Well, the only 100% way to avoid any STI is abstinence. Beyond that, consistent and correct use of condoms significantly reduces the risk, but they have to cover the sore to be effective. So if a sore is outside the area covered by a condom, transmission can still happen. Long-term, mutually monogamous relationships where both partners have been tested and are negative are also very safe. Regular screening is really important for anyone at higher risk. We mentioned gay and bisexual men, people with HIV, people using pre-PP for HIV prevention, or anyone whose partner has tested positive. Then there's partner notification. Public health officials work to confidentially inform sexual partners that they may have been exposed so they can get tested and treated. It's anonymous and helps break chains of transmission. And more recently, there's DoxyPIP.
DoxyPIP, tell us about that.
Yeah, it stands for doxycycline post-exposure prophylaxis. It involves taking a dose of the antibiotic doxycycline within 72 hours after potential sexual exposure. Studies have shown it can significantly reduce the risk of getting syphilis, chlamydia, and gonorrhea, particularly for high-risk groups like men who have sex with men and transgender women on PrEP. It's an emerging tool in the prevention toolkit.
Interesting. Are there any concerns with using an antibiotic like that preventatively? Resistance, maybe?
That's the big question, and something public health officials are monitoring very closely. The potential for antibiotic resistance is a real concern with widespread use, so it's currently recommended primarily for specific populations where the benefit is thought to outweigh the risk, and it needs to be part of a broader sexual health strategy, not a replacement for condoms or regular testing. It's about careful implementation and ongoing research. And of course, we keep coming back to it, but screening all pregnant individuals is a cornerstone of preventing congenital syphilis.
The medical side is just, well, fascinating and complex. But as you said, the biology is only half the story. This disease has this incredible historical footprint. Sir William Osler calling it the Great Imitator wasn't just about medical mimicry, was it? It's because its confusing nature tangled it up in human history itself, a diagnostic nightmare for centuries.
Absolutely. And that takes us right into this long-running debate, almost a historical detective story. Where did syphilis actually come from? There are two main camps. The Columbian theory is probably the most famous. It suggests Columbus's sailors brought it back to Europe from the Americas around the late 15th century. There was a major epidemic, particularly noted in Naples around 1495, shortly after his return, which seemed to support this. People at the time certainly pointed fingers across the Atlantic.
But there's another side to that story.
There is, the pre-Columbian theory. This argues that a form of syphilis, or a very similar treponemal disease like yaws or Bigel, which cause similar symptoms, was already present in Europe before Columbus. Proponents point to things like skeletal remains from medieval Europe that showed damage consistent with syphilis. Maybe it was just less virulent or confused with leprosy or other conditions. The debate still continues among historians and scientists. It shows how disease origins often get wrapped up in, politics and blame, not just pure science.
Yeah, before penicillin arrived in the 1940s, the treatments, well, they sound almost worse than the disease. There's that grim old saying, a night with Venus, a lifetime with Mercury.
Ugh, yeah, that phrase really hits home. For centuries, literally from the 1500s up into the early 20th century, mercury was the main treatment. They'd use it in ointments rubbed onto the skin, or people would inhale mercury vapor. It did have some antimicrobial effect, sometimes it seemed to help, but mercury is incredibly toxic. The cure often led to severe mercury poisoning, neurological damage, kidney failure, losing teeth, constant drooling, tremors. It was truly awful, a terrible choice to have to make.
Trading one hell for another, basically. So thinking bigger picture, history, culture. Syphilis seems to have touched some really famous lives, didn't it? Leading to some interesting historical twists.
Oh, definitely. The list of historical figures suspected of having syphilis is long and, well, star-studded in a morbid way. King Henry VIII, maybe Ivan the Terrible, artists like Van Gogh, Goya, Manet, writers like Baudelaire, Oscar Wilde, philosophers like Nietzsche. The list goes on. Now, diagnosing historical figures posthumously is tricky, obviously, but there's often compelling biographical or medical evidence. What's really fascinating and debated is the potential link between late-stage neurosyphilis, which we know can cause mania, delusions, personality changes, and bursts of creativity or radical shifts in thinking in some of these figures. Could the disease have paradoxically influenced some major works of art or philosophy? It's impossible to prove, but a compelling thought. We even see it reflected in art very early on, like Albrecht Dürer's woodcut The Syphilitic Man from 1496. It shows how quickly this disease grabbed the public imagination.
But the history of syphilis also forces us to confront some of medicine's darkest chapters. Truly profound ethical failures, the Tuskegee study, the Guatemala experiments. These are hard to even talk about.
They're absolutely abhorrent and essential to remember. The Tuskegee study ran from 1932 to 1972 in the U.S. Researchers from the U.S. Public Health Service enrolled hundreds of black men in Alabama who had syphilis. They told them they were being treated for bad blood. But the real goal was just to observe the natural, untreated course of the disease. They actively prevented the men from receiving penicillin, even after it became the standard cure in the 1940s. It was pure exploitation based on race and poverty.
Unbelievable. And Guatemala?
The Guatemala study was shorter, 1946 to 1948, but arguably even more overtly sinister. U.S.-backed researchers, again with government knowledge, intentionally infected hundreds of Guatemalan soldiers, sex workers, prisoners, and patients in mental health institutions with syphilis and other STIs without their knowledge or consent. They wanted to test penicillin. It was a horrific violation of basic human rights and medical ethics.
These are just staggering betrayals of trust. What came out of them? How did medicine respond?
The public revelation of Tuskegee in the 70s caused a massive outcry. It led directly to major reforms in U.S. law and regulations governing clinical research. Things like the requirement for institutional review boards, IRBs, to approve studies, and the absolute necessity of informed consent from participants. These grew directly out of the ashes of Tuskegee and awareness of Guatemala. They stand as permanent, grim reminders of the potential for abuse in research, especially involving vulnerable populations, and why ethical oversight is paramount.
Which raises that crucial question. How do we, as medical professionals, as a society, ensure this kind of thing never happens again? How do we maintain trust, especially with communities that have been historically mistreated by the medical system?
It's an ongoing process, and it requires constant vigilance. It means rigorously enforcing ethical standards through IRBs. It means ensuring true informed consent, not just a signature on a form, but genuine understanding. It means prioritizing patient safety and well-being above any research goal. It means fostering diversity in research teams so they reflect and understand the communities they work with. And crucially, it means remembering and teaching these histories. We can't shy away from confronting the mistakes of the past if we want to build a more ethical future and rebuild trust.
So we've talked about the history, the treatments, the terrible ethical lapses, the cure. But despite all this, despite penicillin, despite the lessons learned, is syphilis actually just a problem of the past?
You'd think so, wouldn't you? But astonishingly, no. It's quite humbling, actually. Syphilis cases have been rising significantly across the globe in recent years. We're not talking about developing nations only. This is happening in the US, Canada, the UK, Australia, across Europe. The increases have been particularly sharp among men who have sex with men in many areas, but we're also seeing concerning rises in heterosexual populations and, tragically, in congenital syphilis cases in some regions. So, far from being a historical footnote, syphilis is a very real, persistent, and growing public health challenge today. It demands our attention now just as much as ever.
A truly humbling thought. So what does all this mean for you, our listener, as we wrap up? This deep dive shows syphilis has truly earned its title, the Great Imitator. Medically, yes, but also historically mimicking progress then resurging. It shaped civilization, culture, ethics, a single bacterium with profound impact. But it's also a story of progress. We have the knowledge about its stages, its transmission, prevention. We have effective treatment. Understanding its cunning nature is the first step towards facing this persistent challenge, both individually and collectively.
Absolutely. And if we connect this to the bigger picture, the story of syphilis serves as such a powerful reminder. It reminds us that even diseases we can cure can make a comeback when our vigilance slips, when public health infrastructure weakens, or when social inequalities create barriers to care. It really urges us to constantly prioritize public health education, fight for equitable access to testing and treatment for everyone, and never, ever forget the hard-won ethical lessons from its darkest chapters. Understanding syphilis isn't just about the medicine. It's about understanding ourselves, our history, our behavior, and our ongoing collective responsibility to protect health. Perhaps the real great imitator isn't just the disease, but sometimes our own tendency to believe a problem is solved only to find it's just shifted shape, waiting for us to look away.